If you visit a clinic with elevated cholesterol, the standard frontline protocol is clear. You will likely be prescribed a statin to lower your LDL and reduce your risk of heart disease. While clinical trials once suggested muscle-related side effects were rare, broad observational data reveals a different reality. Between 9 and 20% of people taking statins develop some form of myopathy. Myopathy manifests as deep muscle pain, physical weakness, and chronic fatigue, symptoms that can become severe enough to force patients to abandon the medication entirely. Why does a drug specifically engineered to protect the cardiovascular system end up degrading skeletal muscle tissue? To find the answer, we have to look past the heart and audit the microscopic power grid operating inside every muscle cell. Skeletal muscle cells are massive, continuous consumers of energy. To contract and repair, they require a relentless supply of microscopic fuel. That fuel is generated by mitochondria, the cellular power plants you see here, embedded directly within striated muscle fibers. These power plants cannot generate energy from nothing. They require a specific biological raw material to function, coenzyme Q10, or CoQ10. When the body's internal CoQ10 supply chain remains intact, the muscles thrive and perform as designed. Statins function as HMG-CoA reductase inhibitors, meaning they are designed to block a specific enzyme in the liver. This intervention is highly successful at stopping the body from producing its own cholesterol. The problem lies in the assembly line. The liver's biochemical pathway creates cholesterol, but also splits off to produce CoQ10. When a statin blockades the top, it halts cholesterol production and completely severs the body's supply of CoQ10. The medication designed to support the cardiovascular system effectively cuts off the primary fuel supply to the muscular system. Deprived of CoQ10, the mitochondria inside the muscle cells completely power down. This creates a severe, localized energy blackout. This energy deficit accumulates over years, as the cumulative loss of CoQ10 incrementally starves mitochondrial output. This chart compares why short-term clinical trials often miss this decay. In a 3-year window, side effects appear minimal, but on a 10-year timeline, the cumulative mitochondrial degradation spikes exponentially. Depleted of fuel, the surrounding muscle fibers cannot sustain their mass, causing them to fray, thin, and slowly wither. Statin-induced muscle pain and atrophy are the physical manifestations of this cellular starvation. The consequences of this biochemical roadblock extend far beyond the muscles. Because cholesterol is the core precursor for steroid hormones, plummeting its levels deprives the body of the materials needed to synthesize testosterone. This mitochondrial decay also compromises how muscle tissue responds to insulin, raising the risk of type 2 diabetes. In the brain, where energy demands are highest, this same fuel deficit is linked to mild cognitive impairment. A strategy focused solely on lowering cholesterol creates a significant biological trade-off, potentially introducing metabolic and neurological challenges in exchange for a lower lab value. For patients who must remain on a statin protocol to manage their risk, functional medicine requires a corrective intervention. You must actively repair the severed supply chain by supplementing with CoQ10, specifically the active form, ubiquinol. This bypasses the liver blockade, keeping the mitochondria running and preventing tissue decay. True cardiometabolic health is about addressing root causes like inflammation. Forcing a single lab number down is an incomplete strategy when it simultaneously diminishes the body's primary energy supply.